about the emotional impact of cancer experience on patients. And I'm going to share my screen with you so you can see the slides. Is that good, Rachel?
Yes, that looks good.
Okay. All right. And I think what we're going to do is save the questions for the end. Okay. So if you have a question, maybe write it down. Or if you have a clarifying question, you can put it in the chat and Rachel will help me to monitor the chat. So we want to address all the questions as they may come up, but we will save most of them for the end. Okay, so if you think about the potential sources of psychological distress for a patient who's dealing with cancer diagnosis and cancer treatment, there is sort of the biological aspect of the disease itself. So having the cancer and what it does to the body, whether it's the impact on the organ function or the shape or causing pain and various physical symptoms such as nausea or vomiting or low appetite and so forth. So everything that happens physically as a result of cancer and cancer treatment. And then sort of the factors on an individual and interpersonal level. So meaning what kind of stage of life the person is. So is this a young person? Is it somebody who's middle-aged? Is this somebody who's elderly? What have their prior experiences been either with cancer or any sort of psychological distress? What are their usual ways of coping with stress? What are their sort of go-to coping strategies? What is their social support? So their immediate partners or lack of partners, extended family, friends, and so forth. Are they spiritual or not? So all of these factors can play a role in how people will deal with the distress that cancer inevitably brings. And then various psychosocial stressors. So for example, the result of cancer and cancer treatment can be disability, sometimes short-term, sometimes long-term, which can have a significant impact on the person's sense of identity and functioning, dealing with changes in appearance, for example, loss of hair, changes in skin appearance, loss of a body part, having to wear a colostomy bag and so forth. Those are significant changes that can have very, very profound emotional impact on patients. And then the whole uncertainty of the disease process and the treatment, prognosis, particularly if it's not a very optimistic prognosis, that can trigger and bring up existential concerns for patients. And so if we think about the psychological response people have on the scale, or a range of different responses that people can experience, we can talk about so-called normative distress. So let's just say shortly after a diagnosis, it's not unusual for people to experience perhaps a lot of anxiety, maybe shock and disbelief, sometimes denial, anger, difficulty sort of to accept that this is actually happening. And then they may go through a process of what we might refer to as adjustment, where they may have symptoms of anxiety or depression that fall into the category of so-called adjustment disorders. So the symptoms are there. Patients do experience some distress, but they're not actually so significant that we would say that they have a diagnosis of, let's say, major depressive disorder or panic disorder or generalized anxiety disorder. So it's kind of this middle ground where patients do have symptoms and they may be bothersome, but they don't necessarily meet the criteria for some kind of a major mental health disorder. And what can happen at this point is that either they can get better spontaneously or they can get better by let's say talking to a therapist or getting sufficient support from their family or friends or doing their own work, let's say meditation, relaxation, and so forth. So there are different ways that they can help themselves to feel emotionally better, But for some patients, sometimes these symptoms continue or worsen, and they do end up, let's say, clinically or diagnostically meeting criteria for a major depressive disorder, as an example. And then they might be referred to me or my colleagues here and be evaluated for treatment and maybe started on medication to help them. So depressive symptoms or depression as a symptom is very common in cancer. But being depressed or being sad does not necessarily mean that you have a depressive disorder, right? Because sadness, feeling down is part of human experience, and that sadness can be more pervasive or deeper when we go through difficult times in life. And when we talk about clinically significant depression, we're not talking about your common sadness, right? We're talking about symptoms that last most of the time, and to meet the diagnostic criteria for a major depressive disorder, they have to last at least 2 weeks in a row. That's one of the requirements when we ask patients, how long have you been feeling depressed most of the time? And if they say, well, just for the last couple of days, they don't necessarily meet the criteria. But if they say, well, for the last 3 months, we need to ask more questions and investigate if they have other symptoms. And those usually include things like changes in sleep, appetite, energy, concentration, feelings of worthlessness, helplessness, hopelessness, and for some patients, even suicidal ideation. We also want to distinguish between depression or sadness and grief. Grief is a normal emotional reaction to some kind of a loss, whether it's a loss of a person that we care about, whether it's a loss of a job, loss of even loss of hair or loss of anything that we consider valuable and important to us, loss of a pet, right? We can experience grief that can look like depression and can sometimes evolve into more serious depression. But it's a different experience, it's a different entity. About half of patients with cancer experience some degree of depressive symptoms. So 50% of people at some point experience depressive symptoms. So it's very common, but again, keep in mind that depressive symptoms are different than an actual diagnosis of depression. And about 10% to a quarter of these patients actually develop clinically significant depressive disorder, in which case we want to talk about treatment and how we can help the patient with their symptoms. Because if we just say, well, you're depressed, okay, you've been depressed for a month now, well, it's normal to feel depressed because you have cancer, so nobody's surprised, so you're depressed, let's wait for it to get better. Well, what can happen is if we don't address that depression, patients suffer more, obviously, and can have a poor quality of life. So for example, their functioning is worse. They may not be interacting with family the same way as usual. Depressed patients often will say that they just want to withdraw from the world. They're not responding to calls. They don't want to see anybody. And it's not that they don't want to see anybody because they don't feel physically well that particular day. It's that they don't want to see anybody because they're so depressed. They don't care. Nothing brings them joy anymore. Patients who are depressed are less likely to show up to their appointments, less likely to take their medications as they should be taking them. If depression worsens their appetite and they're eating less, and they lose weight, when they come for their next chemotherapy, the physician may say, my goodness, you lost a lot of weight. I think I'm going to have to lower the dose of chemotherapy. So you can see the really significant and direct correlation between somebody having untreated serious depression and that impacting their treatment and then potentially the success of their treatment and effectiveness of it. When we're depressed, it's really hard for us to tolerate physical symptoms that we have, right? So for example, pain. The perception of pain is different and much worse when we're depressed as opposed to when we're not depressed. So the burden of these physical symptoms is higher. Depressed patients tend to stay in the hospital longer because depression can alter our ability to focus, remember, and process the information that we're hearing. We may have a more difficult time to really, kind of understand what the physician is telling us and process that when we're depressed. And then we know that depression can actually increase people's desire for hastened death or even suicide. Anxiety is another very common emotional experience in cancer. And similarly to depression, up to about a third of patients can experience clinically significant levels of anxiety. And again, what I mean by clinically significant is that those symptoms are so frequent or so intense that they're really impacting the person's well-being and functioning, and they could actually benefit from treatment. Sometimes it's an exacerbation of anxiety that patients have experienced in the past. So if somebody had difficulties with anxiety in the past, cancer can sort of worsen that for them. For example, panic attacks or phobias. It can certainly, if untreated, it can persist over time and can remain of concern, a concern for long-term survivors. And it also can worsen people's quality of life or health-related quality of life. So what we mean by the quality of life is sort of like the satisfaction in life, but also ability to function well in life, whether it's in our social roles or professional roles. So if anxiety is too much or depression is too much, it's going to impact our ability to function in those roles that are important to us. So what are some of the common touch points where patients really can struggle with anxiety? Not surprisingly, around the time of the diagnosis, right? So when people first learn that they were diagnosed, you can think back on how that experience was for you. It's not uncommon for me to meet with patients who tell me, I was perfectly healthy, and then I find out that I have leukemia. They may have some symptoms just shortly leading up to the diagnosis, but the diagnosis itself was a complete and unexpected surprise and shock. Anxiety is common when patients are anticipating the results of lab work or imaging, right? It's that anticipatory anxiety, maybe a few days or a week, for some patients even longer, prior to going for that CAT scan and then waiting for that discussion with the physician. Sometimes preparation for procedures, particularly painful procedures or surgeries. Sometimes chemotherapy, particularly new chemotherapies, can evoke anxiety for patients who are not sure what to expect, what to anticipate. Fear of recurrence is one of the most common sources of anxiety in patients with cancer, survivors of cancer. And again, the intensity of frequency can be completely on a scale from sort of minimal for people who are able to sort of put that fear in the far, far, far back of their mind and not think about it too much, but it's there. It's there pretty much 100% for 100% of people. Or the other end of the spectrum could be people who are so preoccupied by their fear of cancer recurring that they can't really function very well. They can't really focus on anything else, and it's just bothering them all the time. Sometimes it can be triggered by new physical symptoms or symptoms that are similar to the symptoms that they were experiencing at the time of diagnosis of cancer. So they'll say like, wow, I have this back pain. That's exactly the same back pain I had when I was diagnosed with myeloma. Maybe my cancer is back, So there are sort of situations and triggers that can bring this fear of recurrence on. Financial concerns are a huge source of anxiety for patients, especially if, let's say, the patient was the main breadwinner in the family, and, concerns about paying the rent or paying for the medications and so forth, transportation even. how are they going to be able to get to their treatment if they're not able to get proper transportation? Suffering, for example, fear of pain or pain coming back is certainly another source of anxiety. And then, of course, fears of dying and fears of death. Oopsie. Oh, this one shows up gradually. Okay, so if we don't treat patients' anxiety or certain, cases of anxiety, because not every anxiety is bad and not every anxiety needs to be referred to psychiatry. But if anxiety is severe enough, meaning that it's intense enough, frequent enough, that it's causing a lot of distress, sometimes patients can avoid coming to the clinic. They can avoid, let's say, having a biopsy or going for imaging because they're claustrophobic. They feel like they're alone or they're ashamed or embarrassed by their anxiety, and so they don't tell anybody that they're suffering. Some people self-treat themselves or try to self-treat themselves with substances like alcohol or tobacco or marijuana. Anxiety, too, similarly to depression, can increase suicidal ideation, and it actually comes hand in hand with depression quite often. And so suppose that you go see your oncologist and your oncologist will recognize that you are very anxious or that you are depressed, and they'll say, well, you know what, I'm really worried about you and how you're doing emotionally. I would like you to see my colleague in psychiatry. So some patients will be taken aback and will say, well, what, you think I'm crazy? Why do you want me to go see a psychiatrist? They feel almost offended by that. Some patients welcome that referral and they're happy that there is a resource that they can get help because they're feeling really miserable. And to have sort of the trust and good rapport with your oncologist, I think really help then not only to express how you're feeling, but also to feel validated and understand that your oncologist will make an effort to give you additional help if that's needed, whether that's seeing a psychologist or coming to see a psychiatrist. And for many patients, that implies, well, okay, I'm going to see a psychiatrist and they're probably going to just try to push medications on me because they're just medication pushers, and I'm afraid, right? So this joke is sort of the paradox of, your anxiety could get better with medication, but if you're afraid of medications, then you may not get better. So there are lots of, what I'm trying to say is, I think there are lots of barriers, including kind of maybe cultural and individual barriers that sometimes prevent people from, one, disclosing how they're doing emotionally, but then also accepting help that may be available to them. And overcoming that may not be easy. And many patients come to see me without really having any idea what to expect. And then at the end of the first session, they kind of joke with me and they'll say, well, what do you think, doctor? Am I crazy? So we laugh about that because of course they're not. And for the most part, we can figure out a way to help them feel better. In very general terms, because there are, of course, many ways that one can help themselves to feel better emotionally, and they don't necessarily have to include psychotherapy or medications, but we're really talking about kind of the end of the spectrum where, again, the symptoms are what we would say clinically significant. And again, I'll just repeat it. Those symptoms of anxiety or depression are pervasive, are intense, are causing a lot of distress or contributing to the person's dysfunction, right? So when we're at that point that we really want to help them feel better, function better, some of the first line treatments are psychotherapy that can be individual and or group. Some people attend both individual and group therapy. So for example, support groups can be very helpful. And medication. Some patients elect to start with psychotherapy and see if that can help them. Some patients, on the other hand, elect to go with medication. And there are cases of severe depression or anxiety where patients do need to get on the medication and get better in order to be able to participate meaningfully in psychotherapy. So bottom line, the treatment and what may work the best is individually tailored, right? Based on who this person is, what are their preferences, what might be the best option for them that they have a best chance to get better, to feel better. And it may or may not include medications. So as a psychiatrist, I can tell you a few sort of points or pearls about medications that we use for treatment of both anxiety and depression. Again, both anxiety and depression are generally treated as a first-line treatment with medications are antidepressants, okay? So if somebody suggests, your oncologist or maybe a psychiatrist that you see, I think we should get you on medication, the first-line treatment for that is an antidepressant. And even though they're called antidepressants, they are very effective for anxiety. So even if you're not depressed and your main problem is anxiety, antidepressants are still the most effective and the safest medication to use for that. I included a few examples of medications that you may have heard about, or maybe you have tried yourself, that we commonly use for our patients because these medications are generally well tolerated, but they do take a few weeks for the full effect, which can be really hard to wait for, right? If you're miserable today, you want to feel better tonight or tomorrow. And I'm telling you that we're going to have to stick to the medication and titrate the dose for a few weeks. That doesn't sound very encouraging, but when people are not feeling well, they're willing to, wait, and we don't really have much of a choice, but they can start feeling better a little bit earlier. There are some patients who will come back, let's say 2-3 weeks later, and they'll say, you know what, about a week or two into the treatment, the dark clouds parted and I started to feel better. So that initial effect, the initial response can be a little bit earlier. These medications are not addicting. And that is often the number one concern that patients share with me. And they'll say, well, am I going to be addicted to this? Antidepressants are not addicting, but they work when you take them. So if you want them to work, you have to take an antidepressant every single day. And we generally recommend to stay on the medication for at least 1 year after you feel better, right? And then at 1 year, if you want to see if you can get off of the medication, it's better to do it with somebody who's kind of monitoring you to see if the symptoms of anxiety or depression are coming back, but it's not dangerous in any way to get off of these medications. If you are someone who has struggled with depression in the past or significant anxiety, then you may be better off staying on the antidepressant long-term to keep those symptoms at bay, because antidepressants are not curative. They do not cure depression. They do not cure anxiety. They just prevent it from coming back, okay? And they can be combined with some other medications, for example, benzodiazepines, and I'll tell you more about those, what those are, and other medications that may be used for treatment of other medical conditions that people may have, whether that's, let's say, high blood pressure or chemotherapy. So benzodiazepines are a group of medications that are used for treatment of anxiety acutely. So when one is experiencing anxiety, for example, a very intense panic attack, but they're not used for treatment of depression. And some of the names that you may have encountered are clonazepam, lorazepam, alprazolam, diazepam. What they do is they work on certain receptors in the brain that allow to kind of mediate a sense of relaxation, and they can be sedating. So they can sort of relieve the anxiety right in the moment, right when one needs the most help with it. So they have a very rapid, generally a rapid effect, but then after usually a couple hours, few hours, that effect peters out. So they do not do any prevention of anxiety from coming back. And what happens for some patients sometimes is that, let's say they get a prescription for alprazolam. You may know it also as a Xanax. That's a brand name for that medication. So let's say you get a prescription from your oncologist who will say, hey, you know, I can see you're really anxious. Take this when you feel very anxious. And you go home and you take the medication and you're like, wow, okay, this helps. I feel better. Okay, so then you feel anxious the next day, then you take the medication again. The danger of taking these types of medications regularly, let's say every single day or even a few times a day, is that we can become physiologically dependent on them. So we start needing these medications to actually feel okay. And if we don't have them after we got used to them, we can feel anxious. So we can have sort of withdrawal symptoms if the medication is not available to us. We can also become tolerant to the effects of the medication. So the dose that was effective, let's say a month ago, is no longer effective now. And so patients find themselves escalating the dose. Okay, now I need more, right? Before they know it, they're dependent on these medications. And there is, for some people, not for everybody, but for some people, there is a potential for addiction. These medications work exactly the same way in the brain as alcohol does, right? So if people treat their anxiety with alcohol, the alcohol has pretty much the same effect. So the other danger is, let's say, using these medications, drinking alcohol, and then maybe you have medications for pain. So combining these medications and all of these substances can actually cause oversedation and problems with, you know, suppression of breathing and actual danger of overdose. So we don't prescribe these medications lightly, and ideally they should be used, if they're going to be used, really sparingly, only as needed, as little as possible. And if you use them regularly, then it's better to sort of gradually taper yourself off and get yourself to the point that you don't use them at all, or you just use them on an as needed basis. This is the type of, you know, information and education that I think sometimes we don't do a very good job providing to you when we prescribe these medications. And then we kind of, as a psychiatrist, I often see patients who come to me and they're struggling with, you know, getting off of these medications. Sometimes I'll tell you, not just to complicate the matters, but I'll tell you that if the patient comes to me and they have significant depression with a lot of anxiety, and we start an antidepressant, and we know that that antidepressant is going to take some time to work, we could add, let's say, lorazepam or clonazepam in the meantime until the antidepressant kicks in and start helping with that anxiety. So the patient can have, let's say, lorazepam or clonazepam to take to help them while the anxiety is intense. And then once the antidepressant kicks in, what happens is that the patient comes back, let's say, a month, 2 months after, and they'll say to me, you know what, my anxiety attacks, they're really, they're hardly there. If I have one, it's not as intense as it used to be. I don't need the lorazepam anymore. I can't remember last time I took it. So that's what the antidepressant will do for anxiety, that they will prevent it from coming back. They really tame it so that there is no need or minimal need for these kinds of additional medications. I want to briefly mention, I want to make sure that we have enough time for questions, but I also want to touch on the distress experienced by caregivers. Because, I mean, I don't know how many, if we have any caregivers here today. If we do, they can let us know maybe at the end. But I want to acknowledge that the distress is not unique to the patient, because cancer impacts the whole family or the people around the patient. So of course the patient themselves can struggle with significant distress, but also the people who are close to them. Usually it's the partner, or it can be children, whether young children or adult children. And for caregivers, similarly to patients, the way that they experience the stress and the way that they cope with it can really be impacted or related to where they are in their life stage. So for example, is the caregiver somebody who is partner in the right, and maybe they're planning to have children, or is this somebody who's older and maybe the caregiver is somebody who's starting to struggle with dementia? How much can they understand, how much they can help the patient? Those are very different challenges that these partners at different stages of life can experience and bring into that experience. And similarly to patients' experience, the caregiver too will have different ways of coping with their distress that will depend on their prior experiences, on their usual way of coping, on their social support, on their level of spirituality. Being, let's say, a partner, I'll just use that as an example, but being a partner to someone who is diagnosed with cancer and now has to go through intense treatment and so forth, means that there's going to be an inevitable, even if it's temporary, it's still a change in role and functioning in a family. Because all of a sudden the things that perhaps the patient was doing in the family, they're no longer able to do. So the partner, the caregiver, has to figure out how to do them, how to address them, while at the same time, perhaps being expected to take the patient to their appointment, being expected to provide emotional support and so forth. So there's definitely an increased demands on what they're expected to do. The worry about the patient and what's going to happen can be intense. And sometimes what happens is that caregivers want to hide that worry and anxiety from the patient themselves because they don't want to upset them even more. So they kind of live with that hidden worry. And then the fear of losing loved one and the fear of uncertainty of what's going to happen. How are we going to get through it? The whole family can be shaken by the diagnosis, and they need to reorganize and figure out how to cope. The caregivers or relatives can experience the level of psychological distress that is similar to that of patients, and sometimes even more. The level of distress can depend, as I mentioned, on many factors, and emotions are contagious. So negative emotions can be transmitted between patients and caregivers. We all experience that, right? When we come, let's say, into a place where people are not in a good mood, you can notice that maybe some of that negative mood is starting to rub off on you as well. We're social animals, and we're very attuned to the emotional temperature in the room and to the emotional state of others. And if we're not mindful, we sometimes can, kind of automatically get into a similar emotional mode. What I would like to add to this is that it can be a difficult balance for, let's say, a family or partners to be able to share honestly, emotionally, their fears, their sadness, their concerns, and at the same time be able to contain that emotional experience in such a way that they're supporting each other and that they're able to still cope well. So we want to be honest about how we feel. We don't want to hide how we're feeling, especially not from people that we really trust. We want to be able to provide and get support when we're not feeling very well, but we also want to be able to find ways to cope with those feelings rather than give in to them completely and abdicate on everything, right? Because the helplessness or the hopelessness if it's transient, it's understandable. If it's temporary, it's understandable. But once we get stuck in that emotional mode, it can be detrimental, right, to our emotional health and to our functioning. So as much as cancer and the cancer experience can be very stressful, life-changing for everybody in the family, and we don't even have time tonight to get into, you know, what it could mean for, let's say, children, depending on their developmental stage and so forth. But on the other hand, the whole experience can actually be a source of positive change for an individual patient, or even for other members in the family. And in research, it's been referred to as so-called post-traumatic growth. So the experience itself can be traumatic and very difficult. But when we come out of that experience and we look back, we can use that as a source of perhaps of self-reflection and reevaluation of our relationship to other people. Perhaps find it to be a source of increase in self-worth, realizing one's own courage, resiliency, ability to ask for help, renewed appreciation for so-called little things in life. That's very common for patients, and they tell me that, you know, they'll say, well, you know, the things I thought were important before, I don't think they're important anymore. I have different values. I have different priorities. So in other words, the experience with cancer does not necessarily and automatically have to be all negative. Many patients come out of it what they would describe, I'm a better person now. I like the person I am now better than I was before. So what can you do? Whether you are the patient, survivor, whether you are a caregiver, I know some caregivers don't like that term, but whether you are somebody who is close with someone who's a cancer survivor, there is a lot that you can do. There's a lot that you can claim, including taking care of yourself. And I realize that what I'm going to say may sound like cliche and something that you hear all the time, but I really mean it, because we see the difference in how people do emotionally when they do take care of themselves physically. So eating healthy, even if you eat small meals frequently during the day, but you're paying attention to what you're eating, what you're putting into your body, making sure you rest and get enough sleep. So, you know, turning off the phones, turning off the TV, turning off those distractions that keep us awake when we should actually be sleeping. Sleep is so important for our physical and emotional well-being. Exercise, even if the exercise is minimal, even if all you can do is sit in your chair and stretch your arms, even that's better than nothing. If you can start walking for a few minutes, maybe early in the morning or later in the evening, whatever that exercise is, you don't have to go to the gym 4 times a week. You can just go for a little walk. That in and of itself is enough. So do whatever you can do, whatever is within your power at that point in your life to take care of your physical health. Take care of yourself mentally, of your emotional health. It's important that we de-stress regularly, because life is full of stress. Life is full of uncertainty for everyone, right? Really, none of us has control over what's going to happen to us tomorrow fully, right? What we can control, we can plan, and we can maybe, you know, put things in place to prevent some catastrophes from happening, but we certainly cannot control everything, and we certainly cannot prevent everything. But what we can control is what we do, what we say, and what we think about our situation. Okay, so you may feel very anxious or you may feel sad, and feelings are what they are. They're not something that we choose, right? I don't choose to be sad. I don't choose to be fearful. I recognize that that's how I'm feeling, but I do have the ability to think about what I'm feeling, why I'm feeling it. And I do have the ability to shift, change my attitude towards my feeling, towards my situation, change the perception. So we have the power over our thoughts, right? And how we manage our thoughts then leads to how we manage our emotions and our behaviors. As somebody much wiser than me said, our thoughts are who we are. Right? It's not our feelings, but our thoughts. How are we thinking about ourselves, our situation, the people around us? That we can absolutely change and alter and shift if we make the effort. No matter how bad the situation is, we can always choose how we're going to respond to it. Even if we feel like all control has been taken away from us, the control over our own response to that situation is with us until our last breath. And part of what you can do for yourself on a daily basis is to be intentional about keeping some source of joy in your life. Whatever that is that brings you joy. Is it his hand? To listen to a particular piece of music, to look at the flower, whatever that is. I don't know. It's just I'm making up things that I like to do, but you may like entirely different things that bring you joy. Be intentional about keeping them in your life to the extent that you can. If you cannot do certain things physically, maybe there's something you can do while you're still sitting in the chair, something that you can experience. Spirituality, and not necessarily religion. I'm not suggesting that we all should go to church or synagogue or I don't know, practice religion. Not at all. People can be very spiritual without being religious, and that can bring a lot of comfort and hope to them, because spirituality basically implies that we do incorporate certain values in our life that transcend our physical being or our physical needs. So people who find sources of spirituality in being in nature, or just watching the nature on TV, if that's the best that you can do, just as an example. But it can be an important source of either reinforcing what is meaningful to you, or rediscovering what is meaningful to you, or redefining what is meaningful to you, which is very, very important for our mental health and our well-being. Accept help and support that others are maybe offering to you directly, or maybe that you feel that you need and nobody's offering. If nobody's offering and you need something, speak up. Say what you need. Sometimes people would like to help, but they don't know how. But if you tell them, and you tell them specifically, that's what I need you to do, or that's what I need from you, they can be relieved. Okay, yes, I can do that for you. I'll be happy to do that for you. There are patients for whom it's really difficult to accept help from others, and they have to overcome that. We're social animals, and we're here for each other. We're here to help each other and support each other, and we profoundly, profoundly depend on each other. Humans are not designed to live on their own and be completely self-sufficient. Set healthy boundaries with others. Sometimes patients need to figure out how to protect themselves from, let's say, too many phone calls or emails. Friends or relatives are calling and wanting to know, how are you? So how was the result of the PET scan? If you don't feel like engaging in those conversations, you have no obligation to. You can maybe send a weekly update email to whoever you want to, and that's it. Or you can tell people if they call you, I know you're interested. I'm fine, but I would prefer to talk about how you're doing, or I would prefer to talk about something else. You absolutely have the right to redirect the conversation if you need to. All right, questions. I'm sorry, I probably went longer than you wanted me to, but if there are any questions, now is a good time.
Thank you so much, Dr. Salman. That was so informative and hopeful. Just putting words to universal human experiences and speaking into what we can do to navigate challenging circumstances. So I want to invite people to unmute themselves to ask questions, or you can put them in the chat and I'm happy to ask them for you.
And I'll stop sharing so we can see others if they're here.
Tara, go ahead. I see you raising your hand.
Hi. Yeah, I was specifically about the medications that you were discussing. So when I was going through chemo the last time, my doctor, because I was having problems with my stomach, and the nausea pill Zofran it actually worked for me the first time when I went through chemo. I had no problem with it. The second time I did, I started to get severe constipation to where I ended up in the hospital. And it was because of that. So she switched me to lorazepam. And you were just saying so many words that rang so true for me, because I never got an education about take these only a little bit, don't, because you might get addicted. Well, now it's been over a year and a half and I'm still on them every single day. Now I haven't graduated to the I need more,